My name's Annika Johnston. I'm the Chief Marketing Officer here at Estara, and we're really excited to have you all join us for Spinal Cord Injury Awareness Week and this seminar series that we're doing today. Before we start, I just wanted to do a quick acknowledgement of country. So our team is speaking to you from Ghana country today, and we acknowledge the traditional custodians of the country on which we meet and their continuing connection to land, sea and community. And we pay our respects to elders past, present and emerging, and to any First Nations people here with us today. Before we kick off, I just wanted to give you a quick overview about Estara and who we are and why we're so interested in this week, which is Spinal Cord Injury Awareness Week. So we are the peak body for spinal cord injury in South Australia, and we've actually been around since 1963. We were started by a group of volunteers who wanted to advocate for people in a wheelchair, and we've since grown to become a registered NDIS provider, registered charity, and we're a membership-based organisation with a presence across most of the state. We do a broad range of services, but we've always held really closely onto that spinal cord injury expertise. And so what you can see there is a broad range of disability supports, but also in the green, I guess, our spinal cord specific services that we offer. We've got a highly expert team in-house who've been doing this work for a very long time, and you're going to hear from some of them today. Estara also runs a range of community programs, and these are just a few of them. Again, we've got a number of specific programs to support the spinal cord injury community in South Australia. We're really focused on providing avenues for connection, advocacy, and support. And we do this through our peer support program, through our push through lunches. We run family dinners for carers and family members of people with spinal cord injury, and we have a number of activations at the repact. When we were talking about what we wanted to present during Spinal Cord Injury Awareness Week, our nurses very quickly landed on this theme of back to basics as a topic. They're not going to present you basic information today. Really where this topic came from was an understanding that often when we talk about SCI, we immediately jump to topics like mobility or assisted tech. But what our nurses know from having worked with people living with SCI for a long time is that the basic things are really what is important, and they're the difference between quality of life, dignity, and living well with SCI. And so what they're going to take you through today is a back to basics look at the critical things to think about in terms of care and management relating to skin, bladder and bowel. Our nurses have almost 50 years experience in SCI care between them, and we're really lucky to have them on our team. And I'm going to hand over to Rachel first to take you through skin.
Okay, good morning everyone. For those that don't know me, I'm Rachel, and I've been a spinal cord injury nurse for over 10 years. So welcome, and for those that do know me and have met me recently or at the start of my spinal cord injury nursing journey, welcome as well. It's great to have you on board. So talking skin, not only is skin the largest organ in the body and weighs on average 3 to 10 kilos, it's responsible for protecting the body against trauma, regulating body temperature, facilitating absorption and excretion, like sweating. It senses painful and pleasant stimuli, so touch, feeling, nice feelings, bad feelings. Aids in the production of vitamin D and stores blood. Approximately 8 to 10% of our whole body's blood supply is stored in our skin. So the outer layer, the epidermis, that's our protective barrier. It helps protect us from UV rays, water loss. It's where we have our pigmentation, so our colour of our skin, where we feel sensation. It synthesises that vitamin D and a lot more. Then we've got the dermis level, which is the next one down. It contains the hair follicles, blood vessels, nerve endings, sweat glands. You can see in the diagram there, it's the largest section in the middle. Then you've got your subcutaneous level, which is at bottom, and that's your fat layer. Below that, we go down to muscle. So what happens when our skin is damaged? Everyone has a job to do. There's 4 main phases of wound healing, and they begin pretty much straight away. As my little workers get into it there. I'm going to play a little video here now. Shows what happens on the inside.
In every wound type, the healing process runs through a cascade of phases, which partly overlap in time. The immediate reaction to injury is a contraction of the capillaries to reduce bleeding. Red blood cells and platelets released from damaged blood vessels flow into the wound, aggregate, and produce a plug or clot in the wound. The first step in the inflammatory process is dilatation of the capillaries. Increased permeability of the capillary allows serum and white blood cells to migrate into the wound area. Here, the white blood cells differentiate into different cells, including neutrophils and macrophages. Neutrophils and macrophages are attracted to the damaged cells and bacteria by chemical substances. They become phagocytic and engulf dead tissue and bacteria. Once all the dead tissue is eliminated, the inflammation gradually subsides. During the proliferation phase, the wound is filled with granulation tissue. Granulation tissue consists of newly formed capillaries and connective tissue. The formation of new capillaries, angiogenesis, ensures that nutrients are supplied for granulation tissue formation and is essential for wound healing. Fibroblasts are the predominant cells in the proliferations phase. They migrate into the wound site from the surrounding tissue and start to multiply. In the last part of the proliferations phase, the wound is made smaller by wound contraction. Wound contraction is brought about by specialized fibroblasts with contractile properties called myofibroblasts. When the granulation tissue filling the wound is almost at level with the surrounding skin, re-epithelialization starts. The epithelial cells change shape to facilitate locomotion and crawl across the wound bed to cover it. Migration stops as soon as cells regain contact. The cells change back to their normal appearance and reattach themselves to the basement membrane. The wound is closed. The transition from granulation tissue to scar tissue involves reorganization and maturation of collagen fibers to maximize tensile strength. During remodeling, the fibers are orientated along the lines of tension and cross-linked to form a strong wound. Remodeling can take up to 2 years after wounding.
So what happens if skin cells are damaged in someone with a spinal cord injury? A spinal cord injury disrupts the communication between the nervous system and the immune system. So the inflammation phase is interrupted and veins don't adequately dilate to allow that blood supply to the wound to deliver the nutrients, the oxygen it needs to heal. Less white blood cells also, and the immune cells are available to fight bacteria and infection as well. Dead cells aren't readily removed, So that's that slough that you might find us nurses talking about that we need to remove before your wound can heal. And granulation tissue, which is new blood vessels and collagen containing layer, that formation is as well. So a small area can develop into something much bigger very, very quickly because of all of these impairments, even if the cause of the injury is being removed. For example, if you were sitting incorrectly in your wheelchair or your leg was resting up against the bed rail and what looks as harmless as a red mark in the morning, once you've moved from being against the bed rail or being repositioned in your chair, seems like it is irrelevant, your skin can still continue to break down because it's been without the oxygen and the nutrients for all that time too. And the skin cells start to die. So the common causes of wounds, we've got shearing, which you can see in the bottom right picture there. It's different than friction, which is the next one on the list. So friction is just the slipping of the skin against the surface, where shearing is deeper, where it's the different layers of your skin and your muscle structures below rubbing up against each other. So it's not just superficial surface, it's deeper than that. Pressure causes injury where it stops blood supply to that area, so hypoxia. Incontinence and the moisture that comes with incontinence, whether it's urine issue or a fecal matter, that can be damaging on your skin as well. And then puncture, blunt force trauma, incisions, skin tears, etc. like that. So now what? There's lots of different things on the market product-wise and different nursing techniques that specialised people can choose what's beneficial to what wound you have or what skin concern you have, and also the knowledge behind what works and what doesn't work. It's not a one-size-fits-all procedure where what works for one person will work for the next in the same injury. It really has to be assessed and multiple stages throughout that wound healing. For something as superficial as a bit of redness on the skin, we would use something like linivera oil, which is on the top left, which helps skin integrity. And then it can go as dramatic as needing negative pressure intervention, silvers for infection, highly absorbent foams, and dressings that really pull exudate out of a wound to help it to not macerate, like it's sitting in fluid for too long, breaking down further good tissue. We use an inodine, which is good for infection control as well. Manual debridement, sharp debridement with scalpels are used in clinic. And also then there's the extreme of flap repair, where they take a large portion of your pressure sore area out and pull the good tissue around it back, sort of like patchwork. Prevention is always better than cure. So what can you do? Ensure appropriate fitting clothes and shoes. For example, we don't want studs on jeans, zippers rubbing up against our skin, shoelaces that are too tight, removing any creases that are underneath you once you're placed in your chair, or if you sleep with pajamas on, something as simple as a crease in your clothing can become a problem. Regular maintenance of your equipment, that's where a good OT comes in. What cushion are you sitting on? Is it maintained properly? Are you on an appropriate cushion? Is it a Roho? Is it a gel foam? Is it a combination? Remember your sitting times. Be mindful on how your skin is and how long sitting is for you, whether it only be small hour or two every now and then, or if you can sit up all day without any skin issues because you've obviously got good vascular return. Correct pressure area relief, turns overnight or during the day. Pressure lifts if you're trained to do these in your chair as well, where you can relieve your bottom, going back to bed, tilting back in your chair to offload any pressure on bony prominences. Protective dressings, so foams, we use a lot of foams. put over areas of concern, just to give it a bit of extra padding. Doesn't mean it doesn't need to be checked underneath these dressings as well. Awareness of your medication and their side effects, blood thinners, steroids, anti-inflammatories that thin your blood as well, antibiotics, they all play a part in wound healing. Good hygiene, especially around the continence area too, is very important to keep acids off the skin. Moisturise. If you take one or two things away from my talk today, please moisturise. You really have to look after the outermost layer of your skin. If something can get past that, it can go deeper. And educate yourself and your support team. The more you know, it's always better. Early intervention is critical. So talk to or contact your care team as soon as you have any concerns. Us here at Estara aim to get back to any concerns relating to skin within 24 hours, whether it be having a photo sent through so we can assess it and troubleshoot over the phone, or coming out and physically reviewing your area of concern as soon as possible. Why is that? Because you matter. Thank you very much, and I'm going to pass you over to Wendy. Thank you.
Hi everybody. For those who don't know me, I'm Wendy Husker. I've been this year, actually it's my 35th year of working in spinal cord injury. And today I'm going to talk about bladder. So most important to start with, just with the bladder, before your spinal cord injury, the role of the bladder, we all know where it sits just above in our lower tummy or lower abdomen. It sits in the pelvis and expands to hold urine. Most people can hold between 1.5 or 2 cups of urine comfortably. Some people do have large buckets in there that can hold lots of urine, depending on the jobs that you do and how close you can get to a toilet. The bladder is smooth muscle. It's responsible for contracting and relaxing. The inner lining of the bladder prevents urine from leaking into the body. The bladder sends signals to our brain to tell us when it's full and we need to go to the toilet. And then it sends the signals back to the bladder and the urethra to initiate emptying, also we can have a wee. Sensory nerves in the bladder also transmit signals to the brain, and we can recognise this as discomfort. So what happens when the bladder empties is the bladder wall contracts and the sphincter, which is at the bottom of our bladder, opens and our urethra relaxes so that we can actually void. After spinal cord injury, the bladder and the urethra are controlled by a complex network of nerves, both sympathetic and parasympathetic, and they coordinate to let us void. The brain plays a crucial part in this, coordinating the bladder function and the urination. Damage to the brain or the spinal cord can affect the bladder control and may lead to urinary dysfunction. So that can mean incomplete or no emptying. You can't empty your bladder. Involuntary emptying, which means you leak. It can increase the bladder pressures, so you overstretch your bladder, and that causes the urine to go back up into our kidneys. So it reduces our quality of life because it means that you can have leakage and you have to manage your bladder after a spinal cord injury. Okay, then we've got the different injury levels and the ASIA scoring, and that is really important when it comes to bladder management. And this will be discussed with clients if you've been through the rehab process, when you're in your rehab, or with your doctor or your urologist. So this picture just shows you the different levels. One of the most important areas that is taken into consideration is your ASIA scoring. Bladder function you may or may not get back post spinal cord injury, and the level E means you're normal, supposed to be. This slide shows how the doctors actually do the grading. and they do it with the sensory, which is they check your every level of your spinal nerves, and depending on what score you get depends on what your ASIA scoring. Same with the muscle strength. Your muscle strength is actually what gives you the ASIA B, C, or D. That tells you how much strength you have in the muscle. With a spinal cord injury, there are lots of syndromes, and these are just a few of what are around. The central cord syndrome is one that only occurs in incomplete neck injuries, and it can affect all the body, but once you start to get recovery, it mainly affects your arm and hand function. A lot of clients with central cord syndrome will get some function or all function back in their legs and their trunk, and they may get their bladder and bowel control back, but not necessarily perfectly. Cord recliner, that is the spinal syndrome that is very, very low in the lower back, and that is where the nerves become very, very specific. So often clients with cord recliner can walk, but they have lack of bladder control and bowel control. And then the spina bifida, which is a birth defect. So what does this mean for your bladder? In many cases, because of your spinal cord injury, most spinal clients have what we call a neurogenic bladder. And this is the disruption of the brain's communication with the bladder. Types of bladder dysfunction in spinal cord injury are overactive bladder, which means your bladder twitches, it contracts, or when it's not needed to, when you have often have a small capacity. An underactive bladder or an areflex bladder, it means that your bladder is flaccid, which means that it doesn't contract. A detrusor dyskinesia, that means where your bladder might contract, but your sphincter will not open, so that even though your bladder's contracting, you still can't void. And then reflex emptying. Reflex emptying is what babies have when they're first born, where their bladder fills up and the bladder automatically empties. Clients with a reflex bladder, that will happen. So that's why we teach them self-catheters, or we pick up bladder management that can assist with that. Options. Well, there are quite a few options, but depends on your injury, depends on what your function is, depends on what you can do. Of course, gold standard would be for everybody to be able to wean or go on sensation. There's an indwelling catheter or a urethral catheter, which most spinal clients would have after their initial injury. There's a suprapubic catheter. There's the self-intermittent catheterization, which is the gold standard for bladder emptying. There's a metrophenoff, which is a surgical stoma that is created between the surface of the abdomen and the bladder, which you would need to speak, and you always would need to go through a urologist once it's surgery. And the final one is a urostomy, which is another surgical procedure, and it is a permanent. So what affects your choices with your bladder? Well, the extent of the nerve damage, whether it's complete, incomplete, whether you're going to get some function back, some sensation back. Your age and your agility. This means whether you can transfer, whether you can get your clothing down, whether you can be independent. Hand function, again, means independence, especially with emptying leg bags, self-intermittent catheters, but doesn't mean if you have limited hand function that you cannot do self-intermittent catheters or use a metrophenoff. You can still use these with some limited hand function with adaptive devices. With bladder capacity, if you've got a very, very small bladder capacity, then it can make things more difficult, because it means if you're doing self-catheters, you have to empty your bladder more often. And then the last one is sex. When you go home, or when you're home and you're in a relationship, maybe the choice of your catheter management is really important in your sex life. Then we have some problems that can occur, and some happen just with age, like your enlarged of the gentleman, the enlarged prostate. There's urethral strictures, where urethra becomes narrowed in parts, anatomical deformities, and false passages that can occur when you do self-catheterization. And these are all problems that need to be discussed and managed with your urologist. Autonomic dysreflexia. This is a huge problem for spinal clients with a spinal client above a T6 injury. And I'm going to play a little video so you can, this gentleman can tell you what it's like to live with it.
Things I wish I knew before I broke my neck. Going through the alphabet today is letter A. A is for autonomic dysreflexia, which is scary as The first time I experienced autonomic dysreflexia, I thought I was dying. It literally feels like someone's taking an ice pick and just holding it to your forehead and then just hammering it in with every heartbeat. AD is one of the most scariest things for people with spinal cord injuries. It affects most people above the T6 level. I'm in the C, the cervical level, so that definitely includes me. What is it, you might ask? Well, it's our body's way of telling us that we're in discomfort or pain where we cannot feel. And I can't feel anywhere below my level of injury, which includes my chest, most of my arms, my legs, my bladder, my bowels, all of that. Which means if I really need to go to the bathroom, for example, my body is gonna start telling me with AD, through my blood pressure going up, my head starting to pound, some sweats, that something needs to be relieved or handled. A lot of people like me who experience AD actually can use it to their benefit. Like, it helps me know when I have to go to the bathroom, and then I do that and I feel better. But it can also be life-threatening if you don't take care of it. Fortunately, while I've had pretty severe episodes of AD, I've never had it so bad that I've had to go to the hospital, but I do know friends who have. So did y'all know about autonomic dysreflexia? And tomorrow, what do you think B is going to be?
With autonomic dysreflexia, 9 times out of 10 with clients with in spinal cord injury, a lot of times it's caused by bladder or bowel distension. Other triggers can include pressure sores, ingrown toenails, sunburn, tight clothing, sexual activity. With dysreflexia, it causes a sudden and severe headache, high blood pressure, flushing, sweating above the level of the injury, pale skin, goosebumps, and everybody has their own symptoms when it comes to dysreflexia. So you need to learn your own symptoms. Don't ignore it. It is a medical emergency. And if you are on your own, you need to call 000 and get assistance if you haven't got someone home or you cannot find the cause. With your bladder, a lot of times it's either an overfull leg bag if you've got an indwelling or suprapubic catheter or a kink catheter, if they can easily fix. If it's a block catheter, then again, you need to call for assistance to get your catheter changed. It does occur with clients who do intermittent catheters, but it usually is a sign that, hey, I need to empty my bladder. How it works with a full bladder is that the body is sensing, even though you can't feel your bladder's full, your body actually senses your bladder's full, and it sends the sympathetic nervous system or autonomic system, and it's trying to tell you there's something wrong, and it's trying to fix it. The rise in the BP is detected, and your heart rate drops, and so as a spinal cord injury, you learn what your symptoms are. This side's very, very involved. So how do I know what's best for me? Well, hopefully you actually have had some input if you've been in rehab and you have some conversations. But the first stop in the community would be to talk to one of your spinal nurse consultants or a continence nurse who can provide some advice and may recommend that you talk to your urologist as well. Now I'm going to hand over to Taylor.
Alrighty, so we've reached everyone's favourite topic, bowels. So from injury to independence. And don't worry, I'll try to keep this as fun, real and helpful as possible. And after all, bowels are something we all have, but after a spinal cord injury, they often don't behave the same way. So let's dive into it. So normally your bowel works because your brain and spinal cord send messages back and forth, keeping things moving. After a spinal cord injury, the nerves that normally tell the bowel what to do don't always work the way they used to. That means signals between the gut and brain get a little scrambled, and managing your bowels becomes more of a team effort. It's not just about getting through the day. It's about planning, routines, and finding what works best for you. So we've got a nice image here, but I'm not going to get too technical. You know, we're not all physicians and nurses, but you can think of your bowel like a recycling plant. The small intestine takes out all the good stuff, like nutrients and energy. Then the colon comes in as the drying station. So it removes water and shapes the stool. The rectum is basically storage, and the anus is the exit door or the back door. And if you've ever heard someone say they've got a semicolon, that's not a body part. That just means part of their colon has been surgically removed, often with a colostomy. So a colostomy is when part of the colon is brought out through the abdominal wall, creating an opening or a stoma for the stool to pass through into a bag. So we've got some quick fun facts to keep us all entertained. So your bowel is about 7 meters long, and that's longer than most cars. The total weight of a person's intestines is about roughly 3 to 3.5 kilos. The colon's main job, suck out water and make poop. And your gut is basically a party of 100 trillion microbes. So that's things like bacteria and yeast. It takes 1 to 3 days for food to become food waste. With spinal cord injury, though, it can take up to 2 extra days. If you haven't opened your bowels for 2 days, you might actually be carrying 4 to 6 days worth of stool or poo. So the longer it stays there, the more constipated you can become and the more aggressive the treatment can be required. So early intervention is key. And the best one, a fart can exit the body at 11 kilometers per hour, and that's faster than some people can run. And just one more as well, a more relatable one for everybody. Coffee works as a natural bowel stimulant for a lot of people, so with or without spinal cord injury. So coffee will be your best friend or can be your best friend. Just got a little video here.
Your digestive system consists of all the organs involved in breaking down the food you eat, absorbing nutrients and eliminating waste products. When you take a bite of food, your digestive system is activated automatically. In the stomach, the food is broken down into smaller pieces and digestive juices are added. The now liquid food is passed onto the small intestine, where the nutrients are absorbed and digested. In the large intestine, also called the colon, water and salts are absorbed, causing the waste products to become firmer and turn into stool. The stool is then pushed through the intestine towards the rectum by a series of muscle contractions known as peristalsis. You have 3 to 4 major peristaltic movements each day. The time it takes for food to pass through your digestive system is called the transit time. The average transit time for females is 2.4 days and 1.9 days for males. When stool fills your rectum, nerve endings register that your bowel wall becomes distended, and a signal is sent to your brain telling you that it's time to find a toilet. At the same time, your internal sphincter relaxes by reflex, and stool moves down towards the anus. When you are ready, you consciously allow the external sphincter to relax, and stool is expelled. In between going to the toilet, both the internal and the external anal sphincter are contracted to keep you continent and to prevent leakage.
Cool. So now we're going on to neurogenic bowel. So when we say neurogenic bowel, What we mean is that the spinal cord injury has disrupted the nerves that control how your bowel moves and empties. So this can lead to constipation, accidents, or needing more time and planning to go to the toilet. It sounds frustrating, but the good news is there are clear ways that we can manage it. And it also depends on the level of your spinal cord injury and the degree of the damage of the injury as well for your bowels. So we've got two types of neurogenic bowel disorders. We've got the reflex bowel and we've got the flaccid bowel. So reflex bowel is usually when the injury is a lot higher up and your bowel still has reflex activity, but you may not feel when it's time to go. Or you may have a flaccid bowel, and that's usually when the injury is lower down. The bowel muscles are weaker and don't always move things along as well. So it's really important that you kind of get to know the type of bowel that you have, because that can predominantly shape the strategies and the routines that will work best for you in your bowel care moving forward.
After a spinal cord injury, your digestive system works differently. A spinal cord injury can damage the nerves that help control the rectum. It's difficult to respond to your body's signals in the same way. For example, you may not be able to get to a toilet in time to empty your bowel if you wait until your rectum is full. Therefore, bowel movements require more time and planning. Fortunately, it's possible to retrain your bowel to empty according to a regular schedule. When your digestive system functions differently because of a spinal cord injury, this condition is known as neurogenic bowel. Two types of neurogenic bowel can occur after a spinal cord injury. The type of neurogenic bowel that you have depends on which area of the spinal cord was injured, whether it's above or below the T12 level. Everyone's situation is different and requires individual evaluation and management. But there are two basic kinds of problems people tend to experience: reflex bowel, when the injury is above T12, and flaccid bowel. The type of neurogenic bowel that you have will determine what type of bowel program you have. Both types of neurogenic bowel can be managed successfully to prevent unplanned bowel movements and other bowel problems such as constipation, diarrhea, and impaction. A higher level injury to the spinal cord in the neck or chest area above T12 typically results in a type of neurogenic bowel called reflex bowel. If you have this type of neurogenic bowel, you may not feel the need to have a bowel movement. The reflex that makes you defecate, however, is still there, and the bowel will empty with the assistance of a suppository that triggers the reflex. If you have a reflex bowel, you can use this to have a consistent routine where you empty your bowel on a regular schedule. You can use a suppository to start the bowel movement and digital stimulation to make sure you finish it. People with higher level injuries often use assistance of various kinds with their bowel program. It's important to have a good understanding of the different aspects of your bowel program so that you can explain them clearly to somebody else and direct your own care. People with an injury above the T6 level also need to be aware of autonomic dysreflexia. This is a sudden increase in blood pressure, and it can result from irritation during rectal stimulation or from a blockage of stool in the bowel. Symptoms include headache, sweating, and chills. If you have problems with autonomic dysreflexia, you should contact your healthcare provider. A lower level injury at T12 or below may relax the anal sphincter and damage the reflex that makes you defecate. This is called flaccid bowel. To manage this condition, you may need to empty your bowel more frequently, maybe several times a day. You may also need to use techniques like bearing down or manual removal of the stool. With attention to your diet, you can make sure your stool is the right consistency so you avoid leakage and accidents.
Alrighty, so what now? Where from here? So I want to break it down into something we like to call the 5 rights of bowel management, just to break it down. So we've got the right time, right place, right consistency, right amount, and right trigger. So things like a suppository, but we'll talk about that in the next slide. And basically, we like to call it that we're aiming for the Goldilocks zone. Not too much, not too little, but just right for you. We're looking for this sweet spot where your bowels run smoothly, predictably, and with as little stress as possible. And, not one size fits all. So it's really important that everyone's bowel routine is really individualized and what works for them. Just some little images here. So there are many, many options, and this is what I'm going to talk about for the remainder of my slides and what we can do for your bowel routines. So I'm going to talk about, I like to call, a toolbox of options. There's so many we can use, but we'll start off with oral medications, things like cloxacillin, Movicol, so that's in a sachet that we add water to help get the bowels moving, and they often soften or smooth things along. We've got things like suppositories, which is predominantly known as, like trigger, or enemas, and these give the bowel a push to empty everything. We've got things like irrigation systems, where warm water is flushed into the bowel to trigger movement. This is also known as transanal irrigation, and it seems to be at the moment something that's getting a lot more popular with our clients. We've got manual evacuation, so that's removing stool directly, often needed with flaccid bowels, which I spoke about earlier. I like to think of a flaccid bowel like a muscle that's gone floppy. It doesn't squeeze and push the stool out the way it should because the anal sphincter can be weak. So stool may just leak out when you least expect it. So with a flaccid bowel, the main challenges are constipation and accidents. We've got massages and positioning. Sometimes as simple as leaning forward or an abdominal massage can really help. We also have surgical options like a colostomy with a bag where the stool can go in. Usually that's a last resort when nothing else is working or bowel care is just taking up too much time of someone's life and it's affecting their everyday life. It may sound like a lot, but the key takeaway is you don't need all of these. It's about figuring out what works best for you. The point is there's no single best way. It's all about finding out the right mix for you, your body, and your lifestyle. So diet and fluids matter. This is one of the most simplest but the most powerful tools, diets and fluids. It can really make or break your routine, your bowel routine. Fibre and water can make the difference between a smooth routine and a stressful one. Even small tweaks like more water or less processed food can really go a long way and can really help. Good hydration and a balanced diet can help regulate the stool consistency and make routines much smoother. So yes, again, the morning coffee can be your best friend. And just going back to this table as well, although coffee can be your best friend, it's good to keep in mind that caffeine, dairy, chili, alcohol, and greasy foods or anything out of the ordinary can cause urgency for some. So if you're wanting to keep these foods in, just making sure that you're having them at the correct time to avoid any kind of bowel accidents. It can be really important if you want to reach out to a dietitian as well to help with the personalised plan that you may have. So what does a good bowel routine look like? So a good bowel routine usually has 4 things. Regular timing, so the same time every day, so your bowel learns the pattern. Bowels actually have a memory, which I find really interesting. So try to go at the same time every day can really go a long way. Consistency, so using the same triggers, so triggers being, like a stimulant or your suppositories or enemas, something that will trigger your bowel movements. Techniques, so the massaging, anything that can work for you, and rather than chopping and changing. Good cleanup in skincare, because leaks and moisture can cause skin breakdowns, is similar to what Rachel was talking about, but now with the bowels. And a system for recording what works for you and what doesn't, so keeping like a diary or a memory log or something like that. And just keeping in mind that it takes patience. It can take weeks or months to really solidify that good bowel routine and to make it feel more reliable. But once it's done, it's life-changing. It can really change people's lives. So what can you do to help with this? Identifying your bowel type based on your injury. So working out what kind of bowel you have. Is it flaccid? So what I talked about earlier and before. Sticking to the same time every day. Like I said before, keeping a food diary to see what works and what doesn't. And it's really important that when you're solidifying that bowel routine, that you're changing one thing at a time. So you actually know what's working and what isn't working. Noticing your triggers, so coffee, warm showers, even sex can act as a natural bowel stimulant, which is really interesting. And finally, reaching out to your beloved spinal nurse consultant, dietitians, or GPs for your extra support. And the key take that I want everyone to get from this is that you're not alone in doing this. You have a teamwork behind you, your body and your health team. We're all here to support you, and we love what we do. So please reach out. Just have a personal client story.
There is a lot of negativity associated with my bowel program. Sometimes I hate when that time comes because I get apprehensive, am I gonna have a good one? I've got this to do later on today, and I really need to be, to feel comfortable and to feel healthy. Luckily, I don't have a whole lot of incontinence with my bowel, so to me, that's sort of like a curse and a blessing because I don't have to worry about being incontinent with stool. But at the same time, too, the longer I go without having one, whether it's a couple of hours or whether it's that next day, means that I'm going to have problems with constipation. I have physically had to sort of dig the stool out, and listeners and watchers, please don't be offended. But sometimes you just have to do what you have to do. So I've been blessed because I'm so happy to live my life, not just exist. So I'm basically a pretty happy person, but when it comes to that bowel program, that can be depressing. It can be depressing for me. It can be depressing for my peers. I have a young lady who lives in Arizona that stayed in the house for a whole year because she had problems with diarrhea. And that was last year. And now she's even afraid, to go out sometime because she thinks that she may have an accident. It really affects your quality of life. So when things are going well, sure, it's easy to be upbeat. It's easy to be happy because everything's going your way. But when things are not going well, don't just sit and suffer in silence. Try and find some way to rectify the situation, whether it's talking to the doctors, talking to your peers. And I must say, I do believe in doctors, but oftentimes doctors have this textbook theory. Okay, she's a C6-7, I've had this C6-7, so X, Y, Z is supposed to happen. You do A, and then B, C, D is supposed to happen. It does not work that way. Everybody is different. All of our bodies are different. It doesn't matter if the injury is the same. So it's up to us to find a workable solution, okay? So I would say ask John what's happening with him. How does he manage it? Ask Karen what's happening with her. How does she manage it? And then maybe you try some of that and put what works best for you. Don't let the bowel program control you. You control it. You want to live a happy, productive life. You don't want to just exist going from day to day to day, suffering in silence.
So aging with a spinal cord injury. As we age, bowels naturally slow down, even without a spinal cord injury, and that's the same with the skin and your bladder. So if you've had a routine that's worked for you for years and years and suddenly things change, it doesn't mean you've done something wrong. It just means it's time to reevaluate or reassess with your health team. So small adjustments can keep things working really well. And never feel like you have to put up with things. Check in with us. We love our role and we love what we do. And some small tweaks can make a really big difference and can really make or break someone's bowel routine. If you've always had, so for an example, if you've always had success with a morning bowel routine program, but lately it's taking longer or it's not as effective, it might be time just to reassess. Maybe your diet's changed. Maybe your medications are affecting things, or maybe your body just needs a little bit more support now that you're aging. So an example of like a little tweak, a small tweak like adjusting the timing, adding another stool softener, or changing your positioning could make a big difference in the comfort and effectiveness of your bowel routine. So that's pretty much bowels after in a nutshell, after a spinal cord injury. So thank you for listening. That's me done.
So thank you so much. all of our nurses, Taylor, Rachel and Wendy. We're going to open up for a bit of a Q&A now. There's already one question there, I believe.
Yes.
And so we'll kickstart with that. But if anyone has any other questions, there's a little Q&A box there that you can chuck any questions into, or feel free to raise your hand and we can do it that way. So the first question is, can autonomic dysreflexia occur in people with a SCI level below T6? I might throw that to Wendy to answer.
Yeah, hi. Yes, it has been known for clients as low as a T8 to have autonomic dysreflexia. So I always tell all clients up to T8 that they could possibly have it. It's not common, but it can occur. And all clients with autonomic dysreflexia really should have a dysreflexia emergency card that they carry with them, so that they know that if they are suffering from it and they need assistance, if they do ring 000, ring SA ambulance, that they tell them they've got dysreflexia, because it is that medical emergency.
And we've got a follow-up question as well. Once you have AD, can it occur for the rest of your life, or can it stop happening over time?
What happens is some clients, they learn to manage it and learn to know their triggers or their symptoms early, so they learn how to manage it. But once you have autonomic dysreflexia, it is a lifelong condition.
Right, thank you, Wendy. Are there any other questions from our audience today? I think that's all that's popped up in our Q&A so far. And if not, we will thank you all for coming and participating in Spinal Cord Injury Awareness Week and joining our team. I wish you all the best for the rest of your day. Thank you so much for joining us.